Here's our roadmap for this explainer. First, the classification. Second, management by grade. Third, a key clinical pearl. Fourth, classic exam traps. And finally, a quick recall test. Section 1. Tokyo Guidelines, the classification. Let's dive right in and climb the ladder of clinical severity.
The Tokyo Guidelines brilliantly use the rule of threes to break this down. Basically, we've got three distinct buckets for acute cholecystitis: grade I, grade 2, and grade 3. Grade I, that's mild. It's your baseline patient. They've got acute cholecystitis, sure, but there is absolutely no organ dysfunction and the local inflammation is just mild. Then we pivot to grade 2, which is moderate. Here, things are getting pretty ugly locally, but systemically, the organs are hanging in there. You'll see things like a white count over 18,000, symptoms dragging on for more than 72 hours, a palpable tender mass in the right upper quadrant, or marked local inflammation. And finally, grade 3. This is severe. The absolute defining feature here is organ dysfunction. That local gallbladder issue has officially escalated into a full-blown systemic crisis.
But wait, what actually defines marked local inflammation for grade 2? We're not just talking about a slightly thickened gallbladder wall here, folks. We're talking major surgical complications. Think gangrenous cholecystitis, where the tissue's literally dying. We're looking at collections of pus, like a pericholecystic abscess or a hepatic abscess. It also includes biliary peritonitis, where bile is leaking out and inflaming the whole abdominal cavity, and emphysematous cholecystitis, where gas-forming bugs have completely taken over. If you encounter any of these, you are automatically out of grade 1 and straight into grade 2 territory.
Now we hit the peak, grade 3. The stakes are incredibly high here. What exactly counts as organ dysfunction? Well, you've got to memorize these specific metrics. Cardiovascularly, we're talking hypotension so bad they need vasopressors. Neurologically, it's altered consciousness. The patient is confused or lethargic. Respiratory failure means a PaO2 to FiO2 ratio of less than 300. For renal, watch out for oliguria or a creatinine jumping over 2.0. Hepatic dysfunction hits when the PT-INR goes above 1.5, and hematologically, a platelet count dropping below 100,000. These are the absolute objective red flags that scream grade 3.
Section 2. Management by grade. Because honestly, your surgical game plan completely flips depending on which bucket your patient falls into.
The contrast in our approach is honestly night and day. For a grade I, mild case, the patient is generally good to go for surgery. The definitive preferred move is an early laparoscopic cholecystectomy. You get them to the OR, take the gallbladder out, problem solved. But for grade 3, total shift. This is damage control. For a crashing grade 3 patient, you absolutely have to resist your inner surgeon's urge to just whisk them away to the OR for a lap chole. Instead, your first priority is to resuscitate them, get them into the ICU, and manage that organ dysfunction. Surgery takes a back seat for now.
For those crashing grade 3 patients, lock in this exact sequence of life-saving steps. Step 1. Resuscitate and treat the organ dysfunction with ICU care and organ support. Step 2. Hit them with broad-spectrum antibiotics to fight off that systemic infection. Step 3 is urgent source control, but notice it's not a cholecystectomy. In high-risk, unstable patients, we go with a percutaneous cholecystotomy. That's a drain placed directly through the skin into the gallbladder to decompress the infection. Only after all of that is done, once the patient is actually optimized, do we move to Step 4, definitive cholecystectomy, much later down the line.
Section 3, Key Clinical Pearl. Let's downshift into exam mode with a massive insider secret to anchor your memory permanently.
Here is your golden rule. This is your ultimate cognitive shortcut on exam day. If you remember literally nothing else from this explainer, make it this. Grade I equals no organ dysfunction. Grade 2 equals severe local inflammation, but the vital organs are spared. Grade 3 equals organ dysfunction. Boom, it is beautifully simple. What's super fascinating here is that these 4 criteria are the exact triggers test writers love to use to push a patient into grade 2. You'll be reading a case, the patient seems totally stable, and then, bam! They casually mention a white count of 19,000, or pain dragging on for 4 days, or a palpable mass in the right upper quadrant. Those are your flashing neon signs that you're dealing with moderate acute cholecystitis, and you need to adjust your plan accordingly. Section 4. Classic exam traps. Let's rapidly break down the pitfalls that trip up even the sharpest medical students and residents on the boards.
Hear this loud and clear, guys. Grade 2 is not defined by organ failure. The literal second you see any evidence of significant organ dysfunction, like a sudden drop in blood pressure, a spike in creatinine, or altered mental status, you are officially out of grade 2 territory. Do not let a question distract you with a massive, gangrenous gallbladder and then sneak in a creatinine of 2.5 at the end. The local inflammation might be severe, but organ failure trumps everything. It's automatically grade 3.
And here's the second massive trap: a high white blood cell count. Even an incredibly ugly one like 22,000 does not automatically make the disease grade 3. Look, a high WBC is a marker of severe local inflammation, meaning it's a grade 2 criterion. Don't let a scary-looking white count trick you into diagnosing systemic organ failure. Unless they hit those specific cardio, respiratory, renal, hepatic, neuro, or heme metrics we just went over, an isolated high WBC just means grade 2, period.
Section 5, Quick Recall. Let's put this structured knowledge to the test right now with a rapid active recall challenge.
Okay, a patient presents with acute cholecystitis. Their white blood cell count is 21,000. They've had symptoms for 4 days, but crucially, they have absolutely no organ dysfunction. I want you to think about this for a second. Lock an answer in your head. What is the Tokyo grade for this patient?
Got it? The answer is grade 2 moderate acute cholecystitis. Why? Well, they hit 2 major triggers for grade 2, that white count over 18,000 and symptoms lasting way longer than 72 hours. But because there was no organ failure, they can't be bumped up to grade 3, no matter how high that white count got. If you got that right, you've perfectly nailed the boundaries of this system.
So, we've covered the classification, the step-by-step management, and the classic exam traps of the Tokyo guidelines for acute cholecystitis. The difference between rushing a crashing patient to the OR and correctly diverting them to the ICU for a percutaneous drain, that's a decision that literally saves lives. So, I'll leave you with this. How will you apply these critical boundaries to make sharper, faster, and safer decisions on your very next surgical ward round? Keep this framework in your back pocket, and you'll be ready for whatever rolls through those ER doors. Keep learning, keep pushing, and we'll see you in the next explainer.